Very good morning to one and all. I am Dr. Santosh. Let's discuss the topic on thyroid, anatomy, physiology, and its applied aspects. Um, I hope at the end of the topic, you shall know regarding the development associated anomaly of thyroid and parathyroid gland, its relations, nerve supply, vascular supply, lymphatic drainage of thyroid and parathyroid gland, and its importance, and to know the physiology of thyroid and parathyroid gland. Development. Thyroid gland appears as a epithelial proliferation or as a diverticulum in the floor of pharynx between the tubercle impal and the copula at the point indicated by foramen cecum. The vestigial marking of the thyroglossal duct is a foramen cecum of tongue. Subsequently, the thyroid descends in front of pharynx gut as a bilobe diverticulum. During this migration, the thyroid remains connected to the tongue by a narrow canal, that is thyroglossal duct. This duct later disappears. It reaches its final point in front of trachea in the 7th week. By then, it has acquired a small median isthmus and two lateral lobes. Thyroid begins to function at approximately end of 3rd month. Follicular cells produce colloid that serves as a source of thyroxine and T3. Parafollicular C cells derived from ultimobronchial serve as a source for calcitonin. In this picture, you can see that the thyroid gland which appear from takes its origin from the foramen of cecum, it grows downwards and front of pharynx. Okay, and in the third diagram, it's a dotted lines which depicts the descent of thyroid, the tract that is called the thyroglossal tract, which runs in front of hyoid bone. Okay, and in the last picture you can see that there is a swelling near the hyoid bone. Okay, probably thyroglossal cyst. Developmental abnormalities. A thyroglossal cyst may lie any point along the migratory pathway of thyroid gland, but it always near or in midline of the neck. It is a cystic remnant of the thyroglossal duct. Approximately 50% of the cysts are close or just inferior to body of hyoid bone. They may also be found at the base of tongue or close to thyroid cartilage. What is thyroglossal fistula? It usually arises secondarily from rupture of the cyst but may be present at birth. What is aberrant thyroid tissue? It may be found anywhere along the path of descent of thyroid gland. It is commonly found in the base of tongue. That is called lingual thyroid, just behind the foramen cecum. What is the importance? Aberrant thyroid tissue may be the only thyroid tissue present in the body, so it is very important in that situation. The thyroid gland is a brownish red, highly vascular, placed anteriorly in the lower neck at the level of C6 to first thoracic vertebra. It is ensheathed by a prevertebral layer of deep cervical fascia and consists of right and left lobes connected by a narrow median isthmus. It usually weighs around 25 gram. The gland is slightly heavier in females, enlarges during menstruation and pregnancy. This is the diagram which is telling the relation of the thyroid to thyroid cartilage, cricoid cartilage. Okay, and you can see the two main vessels, superior thyroid vessels and inferior thyroid vessels on either side. Location in the neck, inferior to larynx and cricoid cartilage. The lobes of thyroid gland are approximately conical. Okay, their ascending apices diverge laterally to the level of oblique lines on the lamina of thyroid cartilage, and their bases are level with the 4th and 5th tracheal cartilage rings. Each lobe is around 5 cm long. Greatest transverse and apice extents are approximately 3 to 2 cm. The posteromedial aspects of lobes are attached to sides of cricoid cartilage by a lateral thyroid ligament. The isthmus connects the lower parts of two lobes, although occasionally it may be absent. It measures 1.2 cm transversely and vertically, usually anterior to 2nd and 3rd tracheal cartilages, and it can vary high and low. A conical pyramidal lobe often ascends towards the hyoid bone from the isthmus or the adjacent of the either lobe, more often on the left. The thyroid gland is surrounded by a fibrous capsule derived from pretracheal layer of deep cervical fascia. Extension of this capsule into the body of thyroid create a septa which divide the gland into lobules. The connective tissue firmly connects the thyroid to the larynx and explains why thyroid moves with deglutition. In this diagram, you can see that the carotid sheath is in relation to the thyroid gland, that is in posterolateral in relation to thyroid gland. There are other pictures which is the ultrasound pictures which shows that the hypoechic lesions, okay, depicting the how you can see that vessels and if there is enlarged multinoidal goiters you can see, okay. And is last is the radio thyroid scan, okay, depicting the uptake of isotopes by the thyroid gland. What are the surfaces and relations of the thyroid? The convex lateral surface is attached by sternothyroid. Its attachment to the oblique line prevents upper pole of the gland from extending onto thyroid. More anteriorly lies sternothyroid and superior belly of homohead overlap inferiorly by anterior border of sternocleidomastoid. The medial surface of the gland is attached to larynx trachea contacting as its superior pole in the inferior pharyngeal construction, and the posterior part of cricothyroid is separated from the posterior part of the thyroid lamina and the side of cricoid cartilage. External laryngeal nerve is medial to the part of the gland as it passes to supply the cricothyroid. Inferiorly trachea and more posterior the recurrent laryngeal nerve and esophagus are in median relations. The posterolateral surface of the thyroid gland is in close contact with the carotid sheath, overlaps the common carotid artery. The thin anterior border near the anterior branch of the superior thyroid artery slants down medially. The rounded posterior border is related below to the inferior thyroid artery and anastomosis with the posterior branch of superior thyroid artery. Isthmus is covered by sternothyroid, from which it is separated by pretracheal fascia. More superficially, it is covered by sternohyoid, the anterojugular veins, fascia and skin. Superior thyroid artery is anastomosed along its upper border and the inferior thyroid veins leave the gland at its lower border. In this you can see that veins, okay, superior middle thyroid veins, okay, and its relation. And coming to blood supply and nerves, thyroid is highly vascular and bruit is sometimes heard in the overactive glands. Mainly it is supplied by two arteries, that is the anastomosis with the gland, inferior and superior thyroid arteries. The inferior thyroid artery is a branch of thyrocycle trunk which arises from the first part of subclavian artery, and it ascends along the medial edge of the anterior scalene muscles, passes posterior to carotid sheath, reaches the inferior pole of lateral lobe of thyroid gland. It divides into inferior branch which supplies the lower part of thyroid and anastomosis with the posterior branch of superior thyroid artery, and an ascending branch which supplies the parathyroid gland. The right recurrent laryngeal nerve is intimately related to this artery near the inferior pole of thyroid gland. During thyroid surgery, it gets damaged, which causes hoarseness of voice. And the school of teaching is that you have to ligate it far away from the thyroid gland during thyroid surgery. Superior thyroid artery is the first branch of external carotid artery. It descends, passes along the lateral margin of thyroid muscle to reach the superior pole of the lateral lobe of gland, where it divides into anterior and posterior glandular branches. Anterior glandular branch passes along the superior border of thyroid gland and anastomoses with its spin from the opposite sides across the isthmus. The posterior glandular branch passes to posterior side of the gland and may anastomose with the inferior thyroid artery. External laryngeal nerve is related to this artery, but it is at less risk than recurrent laryngeal during thyroid surgery. Superior thyroid artery is ligated close to thyroid gland to reduce this risk. There is a third artery, that is the thyroidium artery, present in 5% of the people. It supplies the isthmus and arises from brachiocephalic trunk or the aortic arch. The veins, as I told, superior, middle and inferior thyroid veins, 3 veins. The upper and middle drains into interjugular vein, whereas the inferior drains into brachiocephalic vein. What are the lymphatics? Prelaryngeal, pretracheal, paratracheal, deep cervical nodes. Pretracheal nodes or prelaryngeal nodes, also known as the Delphian nodes. Other name is Delphian node. What is the surgical importance of nerves and artery, and what are the landmarks in thyroid surgery? Right recurrent laryngeal nerve ascend on either side of trachea. Each lies just lateral to ligament of thyroid as it enters the larynx. It is about 25%. The recurrent laryngeal nerve is contained within the ligament as it enters the larynx. Right recurrent laryngeal nerve originates from vagus nerve as it crosses the subclavian artery. It then passes posterior to subclavian artery and ascends in a position lateral to trachea along the tracheoesophageal groove. Right recurrent laryngeal nerve can usually be found within 1 centimeter lateral to that or within the tracheoesophageal groove at the level of lower border of thyroid. At the mid portion of thyroid, the nerve might divide into one or two or more branches as it enters the first and second ring of the trachea, with the most important branch disappearing beneath the inferior border of cricothyroid muscle. The nerve can usually be found immediately anterior and posterior to main arterial trunk of the inferior thyroid artery at this level. Okay, the non-recurrent laryngeal anatomy is found in 0.5 to 1% of patients, occurring in setting of arterial anomalies. A non-recurrent right laryngeal nerve can arise directly from the vagus and course medially into larynx. Left side, the recurrent laryngeal nerve separates from the vagus as that nerve travels the arch of aorta. It passes inferiorly and medially to aorta at the ligamentum aurium and begins to ascend toward the larynx, where it enters the tracheoesophageal groove as it ascends to the level of the lower pole of thyroid. A non-recurrent left laryngeal nerve is associated with more extensive anomalies and is very rare. Small branches of the inferior laryngeal artery crosses the nerve at the level of ligament of Berry. So bleeding in this area should be addressed with great caution to avoid nerve injury. What is superior laryngeal nerve? It separates from the vagus nerve at the base of skull and descends towards the superior pole of thyroid along the internal carotid artery at the level of hyoid cornu. It divides into external and internal branches. External branch continues to travel along the lateral surface of the inferior pharyngeal constrictor muscle and usually descends anteriorly, medially along the superior thyroid artery. Within 1 centimeter of the entrance of the superior thyroid artery into the thyroid capsule, the nerve generally takes a medial course, enters the cricothyroid muscle. Damage to the external branch can result in severe loss of quality and strength. Cernia's classification divides into type 1, 2A and 2B of the superior laryngeal nerve. What is space of Reeves? A cricothyroid space of Reeves performing medial dissection at the superior pole of cricothyroid space for ligating the artery and vein individually. This is a critical step in order to avoid damage to external laryngeal nerve. What is tubercle of Zickert candle? It is the posterior extension of lateral lobes. It is found approximately 60 to 70% of people. Whenever found, the auricular laryngeal nerve is usually deep to it, more common in right side. And this is a surgical picture depicting the gland. Okay, strap muscles are retracted. Okay, you can see the superiorly the flap, that is platysmal flap is raised, and you can see the nerves retracted. And in second picture you can see the bipolar cautery which is being used to resect the lobe of thyroid. Okay, you can't use unipolar because it can dissipate heat and cause damage to surrounding structures, as we discussed the auricular laryngeal nerve and the thyroid vessels superior and inferior very close to thyroid, which can be damaged. So it's better to use the bipolar cautery in case you are using it for dissection. Coming to physiology of thyroid hormone. Thyroid gland synthesizes and secretes 3 hormones, T4, T3 and calcitonin. From the hypothalamus, thyroid releasing hormone is secreted, which stimulates the release of thyroid stimulating hormone from the anterior pituitary. Okay, and also causes upregulation of TSH gene transcription. T4 and T3, both these hormones profoundly increase the metabolic rate of the body. Complete lack of thyroid secretion usually causes BMI to fall to 40 to 50% below normal. Extreme excesses of thyroid secretion can increase the BMR to 60 to 100% of above normal. Thyroid secretion is controlled primarily by TSH secreted by anterior pituitary. About 93% of metabolically active hormones secreted by thyroid gland is thyroid and 7% on T3. However, almost all thyroxine is eventually converted to T3 in the tissue, so that both are functionally important. The function of these two hormones are qualitatively the same, but they differ in rapidity and intensity of action. T3 is about 4 times as potent as thyroxine, but it is present in the blood in much smaller quantities and persists for much shorter time than the thyroxine. Thyroid gland is composed of large number of follicles filled with secretory substance called the colloid, lined with cumoidal epithelium cells secrete into the interior of the follicles. The major constituent of colloid is the large glycoprotein thyroglobulin, which contains the thyroid hormones within this molecule. The thyroid gland has a blood flow about 5 times the weight of the gland each when it which is a blood supply as great as that of any other area of the body. To form normal quantities of thyroxine, about 50 milligram of ingested iodine in the form of iodides are required per day. The minimum daily iodine intake that will maintain normal function is 150 microgram in adults. What is this thyroid hormone synthesis and secretion? Iodine is an essential raw material for thyroid hormone synthesis. Dietary iodine is absorbed by the intestine and enters the circulation. The basolateral membranes of the thyrocytes facing the capillaries contain the symportar, that is sodium iodine symportar. Transport two ions on one ion and one iodide ion into the cell with each cycle against the electrochemical gradient for iodide. The sodium iodide symporter is capable of producing intracellular iodide concentrations that is 20 to 40 times as great as concentration in plasma. The interface between the thyrocyte and the colloid iodide undergoes a process referred to as organification. The oxidation and reaction of the iodide with the secreted thyroglobulin is mediated by thyroid peroxidase, a membrane-bound enzyme found in the thyroid apical membrane. When there is a need for thyroid hormone secretion, colloid is internalized by the thyrocytes by endocytosis and directed toward lysosomal degradation. Thyroid functions can be summed up in this way, that is, they collect and transport iodine, they are synthesized thyroglobulin secreted to the colloid, they fix iodide to thyroglobulin to generate thyroid hormones. They remove the thyroid hormones from the thyroglobulin and secrete them into the circulation. Thyroid hormone synthesis is a multi-step process. There are two theories of how this coupling reaction occurs. One holds that the coupling occurs both DIT molecules attached to thyroglobulin. The other holds that the DIT that forms the outer ring is the first detached from the thyroglobulin. T3 is formed by condensation of MIT and DIT, monoiodotyrosine and diiodotyrosine. A small molecule T3 is also formed, probably by condensation of DIT with MIT. The normal human thyroid, the average distribution of iodinated compounds is 23% of monoiodotyrosine, 33% of diiodotyrosine, and 35% T4, and 77% is T3. Only traces of T3 and other components are present. What is the regulation and transportation of thyroid hormone? The plasma proteins that bind thyroid hormones are albumin, that is pre-albumin called thyretin, and a globulin known as thyroxine binding globin. Of the three proteins, albumin has the largest capacity to bind to T4. However, the affinities of the proteins of T4 with which they bind T4 under physiological conditions are such that most of the circulating T4 is bound to thyroid and globin. What is the mechanism of action? Thyroid hormones enter the cell and T3 binds to thyroid receptors in the nuclei. T4 can also bind, but not as avidly. The hormone receptor complex then binds to DNA via zinc fingers and increase the expression of a variety of different genes that code for proteins that regulate cell function. What is the physiological effects of thyroid hormone in brief? Okay, thyroid physiological effects, it has effect on almost all organs, in the heart, in the adipose tissue, muscle, nervous tissue, GIT, okay, and on the fat. What does it do in the heart? It has a chronotropic and inotropic effect. Increased number of beta adrenergic receptors, enhanced responses to circulating catecholamines, increased proportion of myosin heavy chain. Okay, in adipose tissue it stimulates the lipolysis. Increased protein breakdown in muscle, promote growth and skeletal development in bone, promote normal brain development in nervous tissue, increased rate of carbohydrate absorption in GIT, formation of LDL receptors for metabolism in lipid metabolism, calories that stimulated oxygen consumption by metabolically active tissues. Exception is the testis, uterus, lymph nodes, spleen, and pituitary. Increased basal metabolic rate. What is calcitonin? A 32 amino acid linear polypeptide hormone. It was initially considered as a secretion of parathyroid glands. It was later identified as a secretion of the C cells of thyroid gland. It acts to reduce blood calcium, opposing the effects of parathormone. It inhibits calcium absorption from the intestine, from the bones. It inhibits osteoclastic activity, and in the kidney, what it inhibits the renal tubular absorption of calcium, allowing it to be excreted in the urine, thus leading to decrease in the calcium levels in the blood. The parathyroid gland are small, yellowish brown, ovoid or lentiform structures, usually lying between the posterior borders, lower borders of the thyroid gland and its capsule. There are commonly 6 mm long, 3 to 4 mm across, and 1 to 2 mm from the back to front, each weighing about 50 milligram. Usually there are 2 on each side, superior and inferior. The superior parathyroid glands are more consistent in location than inferior and are usually to be found midway along the posterior borders of the thyroid gland, and although they may be higher. Inferior pair are more variably situated and may be within the facial thyroid sheath, below the inferior thyroid arteries and near the inferior lobar poles, or outside the sheath immediately above the inferior thyroid artery, or in the thyroid gland near its inferior pole. Superior parathyroids are usually dorsal. The inferior parathyroid is ventral to the recurrent laryngeal nerve. The parathyroid gland are very flattened in cross section and are not normally visible by clinical imaging methods, including scintigraphy. What the development of parathyroid gland? It develops from second and third pharyngeal pouches. Okay, what will happen to this fourth pouch? Fourth pouch will develop into superior superior parathyroid. The third pouch along will form into the inferior parathyroid and thymus. In the ventral aspect of this pouch, that is third pharyngeal pouch, ventral aspect forms the thymus and the dorsal aspect forms the parathyroid gland. Okay, and epithelium of the dorsal wing of fourth pharyngeal pouch forms the superior parathyroid gland. When the parathyroid gland loses contact with the wall of the pharynx, it attaches itself in the dorsal surface of the caudally migrating thyroid as the superior parathyroid gland. Okay, this is the diagram which shows that the superior parathyroid is developed from fourth pouch and inferior parathyroid is developed from third pouch along with the thymus. Vascular supply. As rich blood supply from the inferior thyroid arteries or form anastomosis between the superior and inferior vessels. Approximately one third of the humans have 2 or more parathyroid arteries. Lymph vessels are numerous and associated with those of thyroid and thymus glands. The nerve supply is sympathetic, either direct or from superior or middle cervical ganglia or via plexus in the fascia on the posterior lobe aspects. Parathyroid activity is controlled by variations in the blood glucose levels. It is inhibited by rise and stimulated by fall. The nerves are believed to be a vasomotor but not secretomotor. Parathyroid hormone is secreted from chief cells of parathyroid gland. It acts by increasing the concentration of calcium in the blood. Parathyroid hormone half-life is approximately 4 minutes. Tests are used to different clinical situation. The average PTH levels is the 10 to 20 picogram per ml. What is the synthesis of parathyroid hormone? Parathyroid hormone is a linear polypeptide. Okay, initially it is synthesized as the pre-pro-parathyroid with 115 amino acids. Later, on the entry of into the endoplasmic reticulum, the leader sequence is removed and the amino acid terminal to form 90 amino polypeptide, that is pro-PTH. In additional, removing the about 6 units of amino acid residues from the amino terminal of pro-parathyroid Golgi apparatus, 84 amino acid polypeptide is packed in the secretory granules, released as a main secretory product of these cells. What is the mechanism of parathyroid hormone? There are at least 3 different parathyroid hormone receptors. One binds parathyroid related protein known as the parathyroid hormone related peptide receptor. Second receptor is PTH2, does not bind PTH-RP and is found in breast, placenta and pancreas. The third receptor, which reacts with the carboxyl terminal, reaches the amino terminal of parathyroid. It is the signal transduction pathways activated by parathyroid hormone and parathyroid hormone related binding. Okay, in this intracyclic AMP is increased via GS and cyclase DAG and IP3 are increased in G4 via G4 and phospholipase C. The regulation of secretion, the control circulating ionized calcium directly onto the parathyroid is a negative feedback fashion to regulate the secretion of parathormone. The key to this regulation is a cell membrane calcium receptors. Activation of this G protein coupled receptor leads to inhibition of parathormone secretion in parathyroid, and in this way, when plasma calcium levels is high, parathormone secretion is inhibited and calcium inhibited deposited to the bones. When it is low, secretion is increased and calcium is mobilized from the bones. This is the graph which is showing the relation of parathormone with the ionized calcium blood in the blood level in the blood. As you know, there is more of this parathormone because of and this serum calcium, ionized calcium, will come down because they are almost antagonist in action. Means parathormone, that maximum parathormone response will lead to decreased calcium. Okay, functions. Parathormone raises blood calcium by acting on three organs, as I told: bone, GIT, and kidney. Bone, what does it do? Breaks down calcium release. Intestine, increases uptake of calcium from the intestine. Kidney, synthesize reabsorption of calcium from calcium in biliary tubules. Parathyroid reduces the reabsorption of phosphate from the proximal tubule of the kidney, which means more phosphate is secreted through urine. Parathyroid increases the activity of 1-alpha hydroxylase enzyme, which converts 5-HTT, that is 5-hydroxycholecalciferol to 125 dihydrocholecalciferol, the active form of vitamin D. What are the stimulators? Decrease serum calcium, mild decrease in serum magnesium, an increase in serum phosphate. Inhibitors increase serum calcium, severe decreases in serum magnesium, which is also produce symptoms of hypoparathyroidism. Parathyroid related peptide, that is parathyroid related protein, is produced by many different tissues in the body. It has 140 amino acid residues compared with 84 in parathyroid. It is encoded by a gene on chromosome 12. Parathyroid related protein and PTH have marked homology at their amino acid terminals ends, and they may both bind to the parathyroid related protein as a marked effect on the growth and development of cartilage in utero. Hypercalcemia is about 80% of patients with certain malignancy due to elevated circulating levels of parathyroid related protein, which lead to high humoral hypercalcemia of malignancy. And here we end the topic. Okay, hope you understood what we thought.